They do. So the fetuses specifically have a risk for something called intrauterine growth restriction. All of these cardiac patients, due to the medications that they're on and also due to perhaps the abnormal blood flow within their heart, it oftentimes may reduce a bit of oxygen to the uterus, let's say blood flow to the uterus, which in turn causes decreased oxygen delivery to the fetus, and therefore the growth sometimes is abnormal, and therefore we follow their growth with ultrasounds. Also, all of these babies of moms with adult congenital heart disease are at risk for heart disease themselves, and so we do something called a fetal echocardiogram. So it's an ultrasound of the baby's heart specifically, where we look at many different angles and views of the baby's heart to try to identify a congenital heart disease defect. Many of them do, not all of them, but many of them have a recurrence risk in the next generation. They are mostly for growth restriction. There's actually very few medications that can't be used in pregnancy. The majority of medications are pretty much safe. And with like every medication or any procedure you do in medicine, there's always a risk and a benefit. And in this specific situation, the benefit outweighs the risk. It doesn't affect the baby unless it affects the mother. So for instance, if a mother is on a very high dose antiarrhythmia, she needs to be monitored oftentimes in the hospital, because if she develops some kind of complication from it, it affects the baby. I would say the most common medication that really causes us trouble is Coumadin, the anticoagulation medication. And that can cause embryopathy, malformation of the baby. But that's only during a certain period in the pregnancy. So there are cardiac patients that need Coumadin for various reasons. And what we do is we stop it between 5 weeks and about 14 weeks gestation. That's when the baby's heart is developing, its brain is developing, its legs, etc. And then in the very last part of the pregnancy, it needs to be stopped as well, because there's no anecdote to it in the case that the mother will bleed, as she will intrapartum. We wouldn't be able to stop it. It would be much more difficult to stop it on Coumadin. It's not that we wouldn't be able to, but the way in which Coumadin can be reversed puts one at risk for embolic events, and that's risky in a peripartum patient as well as a cardiac patient.